$893,000 for someone who just handles paperwork and committee meetings. Derek Sullivan's voice carried across the hospital administrative wing like a scalpel cutting through tissue. Sharp, precise, meant to draw blood. He wasn't whispering. He wanted the entire executive floor to hear this. He wanted me to hear it. I was standing in the hallway outside the conference room, waiting for the elevator, holding a patient chart I'd been reviewing. The administrative offices had glass walls everywhere, part of some architect's vision of transparency that really just meant everyone could watch everyone else get destroyed. Through the clear partition, I could see Derek standing at the head of the boardroom table, his presentation projected on the wall behind him. My compensation package was displayed in a pie chart that made it look obscene. $893,000 annually, plus deferred bonuses tied to surgical outcomes and patient satisfaction scores, plus retention payments spanning 21 years. Derek Sullivan was 37 years old. He wore designer suits that probably cost more than most residents made in a month. His MBA was from Stanford. His previous job was healthcare optimization consultant at some firm that specialized in making hospitals more efficient, which meant firing people and cutting services. He'd been hired 6 weeks ago as the new chief operating officer. His mandate from the board: cut costs, increase margins, modernize operations. His strategy: eliminate what he called legacy overhead. My name is Dr. Cameron Rivera. I'm the Chief of Surgery and Director of Surgical Services at Metropolitan General Hospital, a Level 1 trauma center serving 2 million people across the greater metro area. The title sounds prestigious. It is prestigious, but what I actually do is make sure that when someone crashes their car on the interstate at 2 a.m, we have the right surgeons, the right equipment, the right protocols, and the right relationships with referring physicians to save their life. I'm the reason our trauma mortality rate is 6.2% when the national average is 9.4%. I'm the reason we're the only hospital in the region certified for the highest level of trauma care. I'm the reason insurance companies and referring physicians trust us with their most critical cases. For 21 years, I've built the surgical program at this hospital from a struggling department that barely broke even into a nationally recognized center of excellence that generates $47 million in annual revenue. But to Derek Sullivan, I was just an expensive line item that could be eliminated. Derek arrived with a plan. Actually, he arrived with a PowerPoint deck called Operational Excellence through Strategic Resource Reallocation, which in hospital administrator speak meant fire expensive doctors and replace them with cheaper ones. His first week, he eliminated 3 nursing positions in the ICU, not because we didn't need them, but because he wanted to demonstrate fiscal discipline. His second week, he presented his restructuring plan to the board. I wasn't invited to that meeting. I found out about it from Dr. Sarah Chen, the head of cardiology, who forwarded me the presentation with a subject line that just said, "You need to see this," and 3 exclamation points. I read it that night in my home office, a glass of scotch untouched on my desk. Derek's plan was elegant in its ignorance. Eliminate the chief of surgery position. Replace it with a rotating surgical services committee of junior attendings. Hire a hospital management company to oversee surgical operations. Projected annual savings, $5.3 million. Implementation timeline 60 days. Risk assessment, low to moderate. That risk assessment made me laugh. Not a happy laugh. The kind of laugh you make when you realize someone is about to burn down everything you've spent 2 decades building. Here's what Derek Sullivan didn't understand about running a surgical program. It's not about scheduling operating rooms. It's not about managing supply budgets. It's about relationships. When a community hospital 40 miles away has a patient who needs emergency neurosurgery, they call me personally, Not our operator, not our admin. Me. Because I know they're surgeons. I trained half of them. I've stood next to them in the OR when cases went sideways, when they call at midnight with a patient they can't handle. They trust me to accept the transfer immediately, to have the right team ready, to give them clinical guidance over the phone while the helicopter is in the air. When insurance companies negotiate contracts for high acuity surgical care, they want to know who's running the program. They want credentials, outcomes data, and personal assurances that their most complex cases will be handled by experienced physicians. They want to talk to me, not a committee, not a management company, me. I sent Derek an email, professional, detailed, backed with data. I explained the key personnel clause in my physician employment contract. I explained that our hospital's trauma center designation required a full-time board-certified chief of surgery with specific experience metrics. I explained that our contracts with 3 major insurance networks included provisions requiring continuity of surgical leadership. I attached the relevant sections. I highlighted the financial exposure. I estimated the at-risk revenue at approximately $38 million annually if those insurance contracts were terminated or our trauma designation was downgraded. I sent it to Derek, our CEO, Dr. Patricia Morgan, and hospital legal counsel. Derek's response came back in 43 minutes. Dr. Rivera, I appreciate your input, but we're moving forward with organizational restructuring. Your position will be transitioned as part of the operational optimization plan. We'll discuss transition logistics at the appropriate time. Best, Derek Sullivan, COO. Best, like he was declining a lunch invitation. I forwarded his email to my personal account. I printed a copy and put it in my safe at home. Then I called my attorney, a woman named Grace Nakamura, who specialized in physician contracts and had a reputation for absolutely destroying hospitals that tried to screw over their doctors. Read Section 14, subsection 9, paragraph F, I told her, and then tell me what happens if I resign effective immediately. Grace was silent for a long time. Then she said 4 words. Oh, this is beautiful. Before I tell you how Derek Sullivan's cost-cutting initiative cost the hospital $47 million and his entire career, do me a favor and hit that subscribe button and upvote this post. You're going to need witnesses for this absolutely catastrophic healthcare implosion. Thanks. Now back to Derek, who was currently sitting in his corner office, completely unaware that he just triggered a regulatory and financial apocalypse. The meeting was scheduled for a Monday morning, 7 a.m. in the executive conference room, the one with the view of the medical center campus and the coffee that was always slightly burnt. Meeting subject line organizational transition, Dr. Rivera. No agenda, no details, just me, Derek, Patricia, and 2 people from HR I'd never met, which meant they were outside consultants brought in specifically for executive terminations. I wore my white coat over scrubs. I'd just finished an emergency case that had run until 5 a.m., 32-year-old with a ruptured spleen from a motorcycle accident. We'd saved his life. Now I was about to watch administrators destroy a surgical program. I arrived exactly on time. Derek was already there, sitting at the head of the table, his suit pressed, his tie perfect, looking like he'd had 8 hours of sleep. Patricia sat to his right, her expression carefully neutral. The 2 HR consultants sat together, folders closed, waiting. I took the seat across from Derek. I didn't bring coffee. I didn't bring notes. I just folded my hands and waited. Derek started with pleasantries. Dr. Rivera, thank you for making time this morning. I know you've had a long night. 32-year-old GSW to the abdomen with a ruptured spleen. We had to take out his spleen and repair his liver. He'll live? What did you want to discuss? Derek blinked. He wasn't expecting me to be this direct. We wanted to discuss the future structure of surgical services and your role in the organization going forward. You mean the role you're eliminating? I said flatly. We're restructuring surgical services to align with modern operational best practices. The chief of surgery position, as currently configured, doesn't align with our new organizational model. So you're firing me. We're eliminating the administrative position, he corrected. You're welcome to continue as an attending surgeon if you'd like, but we're prepared to offer you a comprehensive separation package if you choose to leave. 12 months salary, benefits continuation, and strong letters of reference. 12 months salary, for 21 years of building this program, for being on call every third night for 2 decades, for knowing every referring physician, every insurance contract, every regulatory requirement. That's very generous, I said, my voice flat. Derek smiled like he thought we were negotiating. We think it's fair, and we'd like to work with you on a transition plan that ensures continuity of care. I reached into my white coat pocket, pulled out a single sheet of paper I'd printed at 4 a.m. after finishing the case. My resignation letter? 2 sentences, effective immediately. I slid it across the table. I don't think a transition will be necessary, I said. Derek picked up the letter. Read it. His smile vanished. You're resigning, Dr. Rivera. If you resign instead of accepting the package, you forfeit the severance. You'd be walking away with nothing. I looked at him, at his perfectly pressed suit, at his Stanford MBA confidence, at his complete ignorance of what he'd just done. I'll be walking away with exactly what my contract stipulates, I said, which is considerably more than 12 months' salary. Patricia leaned forward for the first time. Cameron, what are you talking about? Section 14, subsection 9, paragraph F of my employment contract. The Physician Retention and Protection Clause. I sent a detailed memo about this to Derek, to you, and to legal 22 days ago. Nobody read it. Did they? Silence. Let me explain. I continued. If I'm terminated, I get Derek's 12 months, but if I resign due to constructive termination, which includes elimination of my position or material reduction of my clinical authority, all deferred compensation immediately vests and becomes payable within 45 days. I paused. 21 years of retention bonuses, performance shares, deferred compensation tied to surgical outcomes and revenue targets. The entire package that was designed to keep founding surgeons from leaving when this hospital was restructured 15 years ago. Derek's face was pale. Additionally, my resignation triggers notification requirements under our trauma center designation. The state requires a full-time chief of surgery with at least 15 years of trauma experience to maintain level 1 status. If that position is eliminated without a qualified replacement approved by the state, our designation gets reviewed and potentially downgraded. One of the HR consultants made a small sound. Furthermore, our contracts with Blue Cross Regional, United Health Metro, and AITA Premium all have continuity clauses requiring the same chief of surgery who negotiated the original agreements to remain in place. If I leave without a minimum 240-day transition with a board-approved successor of equivalent credentials, those carriers can renegotiate rates or terminate. I stood up. The total value of my accelerated deferred compensation is approximately $13.7 million, payable within 45 days of my resignation. The at-risk revenue from insurance contract renegotiations and potential trauma designation downgrade is approximately $47 million annually. I walked to the door. I've already notified the state trauma office and the 3 insurance carriers, as required by my professional and regulatory obligations. I estimate you have approximately 72 hours before this becomes a crisis. My attorney is Grace Nakamura, at Nakamura and Walsh. Have your legal counsel contact her regarding the compensation settlement. I'll need full payment within 45 days, or we file for breach of contract plus penalties. I stopped at the door and looked back. Oh, and Derek. That memo I sent 3 weeks ago, I sent copies to the board chair, the medical staff president, and our accreditation liaison, so they all knew. They knew exactly what would happen. You might want to ask Patricia why nobody thought to mention it to you. I walked out. My hands were shaking slightly, but my voice had been steady. 21 years of delivering bad news to families teaches you how to stay calm when everything is falling apart. I stopped by the surgical lounge, changed out of my scrubs, dropped my hospital ID badge on the charge nurse's desk. Dr. Rivera, she asked, confused. I just resigned, Janet. It's been an honor working with you. Her eyes went wide. I walked out of Metropolitan General at 7:48 a.m. The morning air was cool, and the parking lot smelled like coffee from the cafeteria and car exhaust. By noon, I had 8 voicemails from Derek. By 2 p.m., Patricia had called 6 times. By 4 p.m., someone from the board had left 3 messages. I didn't return any of them. Tuesday morning, Grace called. They want to negotiate, she said. They're claiming the insurance contract language doesn't specifically require you personally. That's fascinating, I said, because all 3 contracts were negotiated with me specifically. The insurance carriers required my CV, my credentials, and personal attestations about surgical volumes and outcomes. It's all in the contract appendices. I know, Grace said. I have the files. Your name is all over them. They have 0 room to negotiate. What do they want? They want 120 days to process the deferred comp payment instead of 45. Absolutely not. Cameron, they're going to argue. Grace, the contract says 45 days, period. If they want to breach, we sue for the full amount plus the 50% penalty clause plus legal fees. The total goes from $13.7 million to over $20 million. Let them try. Silence. I'll inform them we're holding to the contract terms. Wednesday morning, the State Trauma Office sent their inspection notice. Routine review of Level 1 designation compliance, triggered by Chief Medical Officer transition. Inspection scheduled in 45 days. Thursday morning, Blue Cross Regional sent a letter. Contract renegotiation request, triggered by departure of named surgical leadership. Current rates, subject to review pending new leadership credentials. Friday afternoon, the first referring hospital called Patricia directly. They wanted to know who was handling trauma transfers now. They wanted to know if the surgical quality would remain the same. They wanted to talk to me. That's when Derek called my cell phone. I let it ring 4 times. Cameron. His voice was hoarse. We need to talk. My attorney is handling all communications. Please, this is spiraling. The state is threatening our trauma designation. The insurance companies are talking about rate cuts. The referring hospitals are panicking. You have to help us. I don't have to do anything. Derek, I resigned. You eliminated my position because you thought a committee and a management company could do my job. So let them do it. Cameron, please. You know what the really stupid part is? I interrupted. If you'd just asked me, we could have found savings. We could have restructured around me. We could have eliminated redundant admin positions, renegotiated supply contracts, optimized OR scheduling. You could have saved money and kept the program strong. I know. I was wrong. I'm sorry. What do you want? Honor my contract, full payment within 45 days, and good luck finding someone with my credentials, my relationships, and my outcomes to rebuild what you're about to lose. If we pay, will you help with the transition? Will you talk to the insurance companies? I let the silence hang. No, I said finally. I've already accepted the chief of surgery position at University Medical Center. They're building a new trauma program, and they're very interested in bringing over surgeons, referring relationships, and potentially some insurance contracts from hospitals that are experiencing leadership instability. I could hear him breathing. You're going to steal our referrals. I'm going to provide continuity of care to surgeons who've trusted me for 2 decades. If they choose to send their complex cases to a program with stable, experienced leadership, that's their medical judgment. I hung up. The payment arrived on day 43, $13.7 million. After taxes, it was still more money than I'd ever imagined having. Grace sent me a bottle of Macallan 25 with the note, "This is what properly negotiated physician contracts look like." And 3 weeks later, Derek Sullivan was reassigned to special projects, which everyone in the healthcare administration knows means you're being managed out. Patricia retired 6 months later, after the board lost confidence in her leadership following the trauma designation review and insurance contract renegotiations. Metropolitan General's Trauma Center was downgraded to Level 2 after the state inspection. Their surgical revenue dropped 31% in the first year. 2 of their 3 insurance contracts were renegotiated at significantly lower rates. Referring hospital volumes dropped by 47%. Within 18 months, they were acquired by a larger hospital system at a substantial discount. Most of the surgical staff left during the integration. As for me, I built University Medical Center's trauma program into one of the top 10 in the country. We recruited 8 new trauma surgeons. We brought over 23 referring hospitals. We negotiated premium insurance contracts. And my new contract was very carefully written with input from Grace Nakamura, with protections that would make any future administrator think 3 times before trying to eliminate positions to make their quarterly numbers look good. I kept Derek's email framed in my office, not out of spite, as a reminder that the most important operations you perform aren't in the OR. They're the negotiations that protect your ability to practice medicine. And every time some new MBA administrator starts talking about operational efficiency and legacy overhead and eliminating expensive physician positions, I smile and think about Derek Sullivan learning the hard way that healthcare isn't manufacturing widgets. It's relationships, trust, and expertise that can't be replaced by committees and consultants. Thanks for listening, you brilliant healers and fighters. Hit that subscribe button, or your next administrator will schedule you for triple bypass surgery based on a spreadsheet.